right, so now we are going to be discussing the care for the patient that has lower respiratory condition. Next slide. All right, so the lower airway disorder negatively impact, oxygenation, ventilation, and gas exchange. It makes sense, right? Some of the lower respiratory condition can be chronic and progressive, right? Such as asthma, chronic obstructive pulmonary diseases, and cystic fibrosis, right? It is important that we provide meticulous management and lifestyle adjustment to achieve the maximum wellness, right? All the clients who have lower respiratory condition require thoughtful, competent nursing care, support, and medication to best manage the disease. Next slide. We'll start with our first condition, and here we're talking about asthma. Asthma affects about 17 million Americans, and about 5 of them are children. 5 million of them are children. 8% of the children and 7% of adults have asthma. It's more common in women than in men, right? The risk for death from asthma increases with age, right? So some of the risk factors include family history, eczema, and the presence of allergens such as rhinitis, right? The condition tends to affect the bronchial airways, not the alveoli, right? So this is the clearance, not gas exchange, the clearance section. There's airway obstruction and bronchial hyperresponsiveness. That's what you see. This means that you have bronchial spasm, right, or contraction of the small airways and underlying inflammation that is usually triggered by exposure to irritants or other risk factors, including cigarette smoke, mold, pollen, dust, animal dander, air pollutants, occupational irritants, viral infection, nasal polyps, allergic rhinitis, food and drug allergies, and emotional stress. All of these can trigger an asthma attack. Next slide. So what are some of the clinical manifestations? Usually after exposure to a trigger, the client can exhibit some of these symptoms such as wheezing, dyspnea, coughing, increase in sputum, increase in respiratory rate. The patient may also experience chest tightness, tachypnea, which is secondary to the decreased oxygenation or anxiety, from the medicine that they're taking, such as bronchodilators, right? A classic sign of an asthma attack is inability to speak in full sentences, right? Inability to speak in full sentences. So in terms of diagnosis, we want to look at, different things. History is important, pulmonary function test, x-ray, pulse ox, and ABGs, right? And then in treatment, you're going to treat to see medications, or certain medications are used here. So treatment include monitoring very closely. You can do the peak flow. You can do peak flow, and then just left medication at home, so that the patient can monitor and see if their condition is actually worse at home, right? So it's zoned into different colors: green, yellow, and red, and so that would help them to identify if they fall in the safe zone in green or one in zone yellow. The medications that we use are anti-inflammatory drugs, right? So typically inhaled steroids, which would help reduce the swelling, the mucus. All of this will make the airway less sensitive and less likely to react to asthma triggers and cause asthma symptoms. And then you have your bronchodilators. These are the beta-2 adrenergic agonists, which their job is to help relax the bronchial smooth muscle, which helps open the airway, so therefore decreasing the obstruction, right? And then there's anticholinergics, which are another group of bronchodilator. So you want airway, because remember asthma constriction, so you want it to open. So ineffective airway clearance is a big nursing diagnosis for asthmatic client, right? All right. Are there some complications that we should be aware of? Absolutely. One of the complications for asthma is status epilepticus, right? So this is a life-threatening emergency requiring prompt treatment. So this person is having an asthma attack that is longer, right? So treatment, what we're going to give them: oxygen, IV fluid, systemic bronchodilators, and steroids. And so remember, when the client is taking the steroids, then you have to look at all the other effect that steroids cause, all the good things it does, but all the bad things it does. Immunocompromise, growth, shunt the growth of a child. So keep that in mind. Make sure you review the steroids and what are some of the things that you need to teach the client about. All right, next slide. All right, so now we're talking about chronic obstructive pulmonary disease. It's projected to be the third leading cause of death by 2020, right? It's also projected to rank fifth in 2020 in the disease worldwide. In 2013, 13.5 million people in the United States, 18 years of age and older, were estimated to have COPD, right? However, the lung function test shows that up to 24 million people may have the disease, indicating an underdiagnosed COPD. So this is really a prevalent thing, and we have to be concerned, especially when you're talking about someone 18 years of age having COPD. Their life has just begun, and you could tell that COPD is one of the diseases that is really debilitating to the point where the patient is not able to be functional in that state. So the pathophysiology is the airflow. There's limitation, which is progressive, right? Progressive means it gets worse, it doesn't get better. And it's associated with abnormal inflammatory response to the lung or noxious particles or gases. COPD has some differences. One of the COPD is as emphysema. It's a disease caused by destruction of the alveoli. So, the bottom, the little like grapes, those part, the one that helps with gas exchange, diffusion, those are destroyed. All right, and then you have chronic bronchitis, which affects the small airway and is defined as what? A presence of cough, right? So this is the classic differences, right? Regular bronchitis versus chronic bronchitis. So with the chronic bronchitis, which is considered COPD, there's a cough, right? And that cough has sputum production, and that sputum production lasts for about 3 months in each of 2 consecutive years, right? So that is considered chronic bronchitis. Next slide. So this is just a graph showing you the destructions in the alveoli in emphysema versus the chronic bronchitis, right? So the normal lung versus the lung of a COPD. That's what you're looking at. Next slide. So what are some of the clinical manifestations? It includes definitely increase in workload of breathing and shortness of breath. That's big clinical manifestation. And you see that the evidence of them working hard by the use of accessory muscles and the patient assuming the tripod position to help ease the work of breathing, right? The patient also appears to have a barrel chest, and in this what you see is that the AP diameter, so the anterior posterior diameter, as compared to the transverse diameter, is 2 to 2 rather than 1 to 2, right? So I would suggest you go and look in your book or look for a picture that shows you this change in the diameter, all right? And then in terms of management, well, the diagnosis, is based on first making sure that we have proper history, the history of smoking and so forth, physical assessment, and you'll see in the assessment, you see this barrel chest in some cases, and you do an x-ray. It's typically done to rule out that other causes of respiratory distress. Spirometry is used measure of the lung volumes and volumes and outflow. And so they're looking at the forced tidal capacity usually. And then in terms of treatment, the COPD, there's 4 goals usually to treat this condition. So 1 is assessment and monitoring of the disease. 2 is to reduce any risk factors that they may have. 3, manage the stable COPD. And 4, manage when they do have exacerbations, right? So in terms of the assessment, what are we going to assess? Regular pulmonary function test, chest x-ray with exacerbation to identify if there's any thoracic anomalies or other progressive changes that we will not show up. All right. And in terms of, the treatment, you use steroids. Steroids is the mainstream of, treatment. And there's a difference between a COPD, emphysema, and chronic bronchitis, the pink puffer versus the blue bloater. Make sure that you review those two different, the differences, because with the emphysema, the problem is destruction of the alveoli versus the blue bloater, right? So you have obstruction, the mucus is so much that it obstructs the flow of oxygen, right? So someone who has a COPD, they're in the hospital, we're not just going to give them we're not going to give them oxygen, right? The COPD, we're not going to give them 10 liters nasal cannula, right? Because a lower O2 is better for these guys because their stimulus to breathe is no longer you'll see the carbon dioxide like us, so there's this oxygen. So by giving them an increased amount of oxygen would stop their stimulus to breathe. Okay, and the guys that have COPD initiated. So energy is really, really important because breathing takes energy, and so we got to try to conserve their energy reserves and so forth. All right, thank you. Next slide. Next slide is cystic fibrosis. This course was discussed in pediatrics, but pretty much cystic fibrosis is a condition that inherited condition. So it is inherited chronic disease that affect the lung and digestive tract, right? It's about 70,000 affected individuals worldwide, right? 30,000 children and adults in the United States are affected. 1,000 new cases are identified annually, right? The disease is most commonly affected Caucasian of Northern Europe descendant. Males and females are equally affected. Black, Hispanic, Latinos, Asian Americans, and African American Indians have low incident rates of cystic fibrosis. Again, it is a genetic disorder of the endocrine gland, right? So the gland that secretes hormones into the duct, also called the duct gland. Here, so there the sweat, the salivary and pancreas gland. It causes the defective gene, the cystic fibrosis transmembrane conductance regulator, the gene that carries by both parents. In order for someone to have cystic fibrosis, it means that mom and dad either carries the trait or the disease. Okay, so if one of them have the trait or the disease, the child can never have the disease because it's a recessive genetic disorder, right? You need both parents to pass it on. So the question is, what is the percentage of every pregnancy if mom has the trait and dad has the trait? What is that percentage? I want you to calculate that percentage and be ready to discuss it in class. Okay? All right. So what are some of the clinical manifestations? The clinical manifestations are related to the organ system affected and can vary significantly from a patient to patient, right? So it includes symptoms such as increased work of breathing, and the evidence of that is tachypnea, irregular breathing pattern. The patient may present with diaphoresis, nasal flaring, pursed lip breathing, intercostal muscle retraction, and use of accessory muscles. In terms of management, diagnosis is the cystic fibrosis is done, and the gene, and that is seen, and usually increased level of chloride is noted in the sweat because of the impair of sodium chloride reabsorption. So it tastes salty, right? What is the management? So this is a lifelong condition. So the patient with cystic fibrosis take the same medication as other patient with lower respiratory disorder. So there's bronchodilator. So it's for them, it's probably best to do the bronchodilator. So you open up the airways, and then you do percussion to try to drain the mucus. They may take also mucolytics to thin the mucus out, so increase in fluid to help thin the liquids and so forth. Okay? Next slide. All right, so this the next condition is the lung cancer. It is the second most common cancer in men and women. It's the number one killer, cancer killer in the United States for men and women. Black men have a higher incidence of lung cancer than the white male, while the white women have a higher incidence than black women, but women have an overall lower rate, right? So the number one cause of death is not cancer, is cardiac disease. All right, so pretty much with cancer is abnormal proliferation of cells. In this case, abnormal cells. In this case, it's the lung, and it's usually two types: non-small cell and small cell. So non-small cell cancer represent about 85% more of the lung cancer and consists of three different types of cells. They are squamous cell, adenocarcinoma, and large cell. The 5-year survival rate for these diagnoses with non-small cell, it's usually 5 years. In early stages is good. So what are some of the next slide? Some of the manifestation are typically not apparent early in the disease, right? So in the disease, you don't know that you have it. But, as it progresses in advanced stages, you start seeing things. And usually you see like a new cough that does not go away, or change in chronic cough, hemoptysis, shortness of breath, wheezing, hoarseness, and chest pain. Headache and bone pain may also be present, right? So in terms of management, they will do chest x-ray, CT scan, PET scan, sputum cytology, bronchoscopy, medioscopy. So a lot of scopes to see and diagnose it. And then based on that, they'll figure out what needs to be done. Usually they will start, next slide. Usually they'll start to do, treatment first, surgery. So there's different types of surgery. So they can do a lobectomy to remove cancer cell localized in one lobe, a wedge resection of cancer localized in one small area of the lung, and a pneumonectomy for cancer that spread diffusely in the lung. All right, so that's what this image represent. Next slide.